start recording. Hey, Mohini, I've started recording.
Okay, thank you, Song. And if I can request everyone to mute their microphones so you can hear me okay. Hello, everyone. Welcome to the July 2017 FRESH webinar. FRESH webinars being a series of web presentations by leading policymakers, researchers, and implementers in school health and education for children in low and middle income countries across the globe. This month, we are commemorating World Youth Skills Day, which was on the 15th of July. And today we have with us our two presenters from the World Health Organization. I'll be introducing the first presenter, Yuka Makino, who is a technical officer at the Health Promotion Unit in the section of Non-Communicable Diseases at WHO. Yuka is a doctorate in dentistry, and she has been with the WHO for the last couple of years, supporting with the development of the WHO global strategy against early childhood caries and the capacity building of national school health programs using the WHO Health Promoting Schools framework. Welcome, Yuka, and we look forward to hearing about the Global School Health Initiative from WHO.
Hello, this is Yuka. Mohini, thank you very much for introduction. Today, from my side, I'd like to talk about WHO Global School Health Initiative and health promoting schools and the latest guidance from WHO. This is an outline of today's contents. Firstly, I'd like to make a brief presentation about recent health status, health promoting school as an effective approach to promote health. After that, I will introduce WHO tools. And then finally, I'd like to talk about moving to health promoting school agenda in low resource settings. Due to a decline in the number of deaths in earlier childhood in many countries, non-communicable disease, NCD, injuries, and mental health are the emerging priority in the global child health and adolescent health agenda. This slide shows estimated top 5 causes of adolescent disability adjusted life years (DALY) lost by sex and age 2015. In 2015, an estimated 1.2 million adolescents aged 10 to 19 years died. Over 2/3 of adolescent deaths occurred in low and middle-income countries. Many adolescent disease and injury are actually preventable and treatable. Moreover, adolescence is a period when many risky behaviors start or are consolidated, having a major impact on health as adults. Risk behaviors include such as unhealthy diet, physical inactivity, substance abuse, and sexual risk behaviors. However, at the same time, this period provides opportunity to develop healthy life skills. Schools provide an efficient and effective way to reach large number of population. Behaviors and habits develop in childhood, and children acquire basic knowledge and experience that influence their life in adulthood. By promoting healthy behavior from childhood and through school setting, it enhances the life of other family members and community as well. Although a significant number of school-age children are unfortunately not in formal education, the compulsory school years provide an easy entry point to engage this age group and adapt healthy lifestyle for lifelong lifetime health promotion. In 2013, over 90% of children of primary school age and over 80% of children of lower secondary school age were enrolled in school globally. Therefore, schools provide an efficient and effective way to reach large number of population. Over the past 40 years, there have been several international initiatives to define and advance the role of schools in promoting and protecting health. The general direction of the WHO Global School Health Initiative is guided by the Ottawa Charter for Health Promotion. In 1995, the WHO facilitated a process leading to the establishment of the Global School Health Initiatives. This initiative advanced a comprehensive and integrated methodology for school health that has become widely known as Health Promoting Schools. The Health Promoting School program may well be one of the most widespread setting-based approach. The WHO defined that a health promoting school is a school that constantly seeks to strengthen its capacity to promote healthy living, learning, and working conditions.
A lot of people are having sound issues, and I've actually.
This figure shows the key feature of health promoting school.
Complain after they sign off and sign back in.
Oh, okay.
But
streams of.
Although a significant number, based on this health promoting school concept, various WHO programs have used schools as a setting for promoting and management health. For example, non-communicable diseases such as school policy framework, implementation of the WHO Global Strategy on Diet, Physical Activity and Health, marketing of food and non-alcoholic beverages to children were developed. Besides NCD, the school is acknowledged as an important setting for promoting health, including adolescent health, communicable disease, as well as cross-cutting agendas such as Shanghai Declaration on Promoting Health in the 2013 Agenda for Sustainable Development. This is an example. Ending Childhood Obesity Report provided 6 recommendations to ending childhood obesity. One of the recommendations is implement comprehensive programs that promote healthy school environment, health and nutrition literacy, and physical activity among school-age children and adolescents. Leo, my colleague, will explain about more detail of this Ending Child Obesity report later. As you understand, the WHO toolkit are available in various health agendas. However, how about the implementation of the school health promotion program, especially in low-resource settings? This is the current situation at school level in low-resource settings. In low and middle-income countries, school-based intervention has been successfully implemented to prevent communicable disease and other health problems, such as worm infection, malaria, diarrhea, iron deficiency, malnutrition, and oral diseases over the past 20 years. However, evidence to prove the effectiveness of a health-promoting school approach in controlling the risk factor for NCD is still scarce. As mentioned, there is various WHO toolkit. Moreover, even in low-resource settings, prevent communicable disease and other health problems such as worm infection, malaria, diarrhea has been implemented. In order to move forward to implement school health programs successfully in low-resource settings, what will be our key factors? WHO School Health Meeting was held in Bangkok 2015 to identify barriers and facilitators to implement school-based health promotion. After this meeting, participants concluded the key factor for implementing school health programs successfully with limited human and financial resources. I'd like to summarize 4 key factors from this meeting. Firstly, utilizing the existing school health programs platform. School-based NCD prevention is not well conducted at this moment. However, even in low-resource settings, schools have experience in conducting school-based health promotion. Therefore, to ensure cost and time efficiency, it is better to utilize the existing school health programs platform. Secondly, for example, to combat childhood obesity among school children, not only Ministry of Education, Ministry of Health, but also Ministry of Finance were allocated resources, Ministry of Land Infrastructure Transportation to promote active transports. So that kind of multiple collaboration is important to conduct comprehensive school-based ending childhood obesity programs. Therefore, the coordination among inter- and intra-ministerial level will be required. In addition to that, leadership of Ministry of Education is inevitable. Various WHO toolkits are being produced. However, without integrated approach, it is quite difficult to cover whole topics. Therefore, it is required to integrate various elements into one comprehensive package. Moreover, the school-based promotion should be part of the national framework for health promotion. In addition to these factors, institutionalized capacity building of teachers, health personnel, and government staff will be required to conduct school-based health education sustainably. In conclusion, key take-home message will be, global disease burden has changed. Health promoting school is an effective approach to promote health. WHO has provided various materials for school-based health promotion. Key factor for successful school health implementation in low-resource setting will be, utilize existing school health programs platform, coordinate multi-stakeholders, and integrated approach, then finally, institutionalized capacity building. Thank you very much for your kind attention.
And the key factors that are necessary for a successful program in low resource settings. I would now like to introduce our next speaker, Leo Niederveen, Technical Officer at the World Health Organization, based in the Surveillance and Population-Based Prevention Unit of the Department of Noncommunicable Diseases. Leo will be sharing with us the global strategy on diet, physical activity, and health. Leo has been with the WHO since 2012, providing technical support to countries in childhood obesity prevention, fiscal policies on diet, salt reduction, and the promotion of physical activities. Leo, over to you.
Okay, good morning, good afternoon, everyone, and thank you very much for this opportunity. So I will speak about the promotion of healthy diet and physical activity within the context of the health promoting schools. But first of that, I will speak a little bit about the non-communicable diseases and why those diseases are so relevant for the low and middle income countries. I will also speak about the causes and determinants of obesity and the changing diets and the commitments that exist at global level to prevent and control non-communicable diseases and obesity. And then I will mention what schools or the education sector together with the health sector can do to develop a school policy on diet and physical activity. So first of all, I will speak more about the non-communicable diseases because they are currently slowing down the development of low and middle income countries. 60% of global deaths in the world are due to the non-communicable diseases, and we normally speak about 4 main non-communicable diseases which make up 80% of all the NCDs. So those are heart disease and stroke, diabetes, cancer, and chronic lung disease. And they share 4 behavioral risk factors, which are tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. By addressing those risk factors, we can prevent between 60 and 80% of those non-communicable diseases. So it's really important that we work on that, because as we know, the treatment is very, very difficult. And we can see on this next slide that the NCDs are having a huge impact on developing countries. When we look at the percentage of deaths due to non-communicable diseases, it's not anymore a problem of the only developed world or of the rich people, but it's a problem that is worldwide and in many countries coexisting as well still with the communicable diseases. And this has a huge impact as well on the development of countries. Due to globalization, urbanization, and aging population and poverty, the lifestyles in countries and the environments, they are changing. This has an impact on the population in low and middle income countries. They are now increasingly exposed to the risk factors like unhealthy diet, physical inactivity, tobacco consumption, alcohol consumption, which of course implies that they are spending money in things they don't need, and this leads to more communicable diseases, and due to these diseases they also have increased healthcare costs, which both for the households lead to out-of-pocket expenses, and as well it leads to a slower development of the countries, especially because most of the people who die from the NCDs in low and middle income countries die between 30 and 70 years of age, which is what we call the premature mortality, and those are the people that are actually in their active age and should be raising incomes for the household. So all this leads to poverty at household level, and this is a vicious circle which is slowing down the development of nations. Let's speak a little bit more about the causes and determinants of obesity and changing diets, because obesity is an important risk factor as well for the NCDs through the unhealthy diet and the physical inactivity that leads to obesity and that leads to the NCDs. So as I mentioned, it's not anymore a problem of high income countries, but also of low and middle income countries, as you can see in the map represented here. So in 2014, 39% of adults aged 18 years and older were overweight, and in that same year 11% of men and 15% of women were obese. Obesity has nearly doubled between 1980 and 2014. When we look at the data we have for children under 5, we see that in 2016, according to the latest joint estimates of World Bank, UNICEF and WHO, 41 million preschool children were estimated to be overweight. And in Africa, this was 9.8 million, up from 6.6 million in 2000. We can also see in the slide that currently the countries with the highest rate of childhood obesity in under 5s are the middle income countries, and that the increase of overweight and obesity in low and middle income countries is much faster than in high income countries. And there are several factors that have to do with the rise of childhood obesity. As a direct factor, we could mention the increased food consumption of energy-dense, nutrient-poor foods, or foods high in energy, fat and sugars and salt. And then we have decreased energy output through physical activity. And the indirect influences are related with the parents and the family, increasing incomes, the working habits of parents, the advertising of unhealthy foods and beverages, a physical environment that doesn't allow much physical activity and that It does allow easy access to unhealthy foods and beverages, restricted access to sports areas, the safety question. Then, of course, knowledge factors are also important. The school environment and also the peer behaviors and preferences. Those are some of the underlying factors related to the rise of childhood obesity. Importantly also is the growth of the ultra-processed food markets. This is growing everywhere, but we can see that particularly in low and middle income countries, the growth of packaged foods has been 1.9% per year, while the growth of soft drinks has been 5.2% per year, which is a very fast growth and growing much faster than in high income countries. This slide shows some of the dietary changes that Mexico has gone through between 1984 and 1998. We see in this slide that there has been a decrease in the consumption of fruits and vegetables, dairy products, meat, chicken and eggs, while there has been an increase in the consumption of refined carbohydrates and sodas. So this is all contributing to the epidemic of obesity and non-communicable diseases. This nutrition transition that we move from traditional unrefined foods with fiber and lots of fruits and vegetables to foods that are high in fat, sugar and salt and often heavily promoted. So there are some global commitments in prevention and control of NCDs and childhood obesity, which I would like to mention. And a very important meeting has been the UN high-level meeting on NCDs, which took place in September 2011. And that was only the second time that a health topic has reached the agenda of the UN General Assembly. The first time was HIV/AIDS. And the second time was the topic of the NCDs, which shows as well the recognition that NCDs are very relevant for development of low and middle income countries. A declaration was signed there, and there are several other high-level meetings where progress is being reported. Also, WHO established a global action plan on prevention and control of NCDs, and that plan includes 9 indicators, 9 voluntary global targets and 25 indicators. There is an indicator on physical inactivity, which the indicator is that by 2025 countries should have a 10% reduction of physical inactivity. And there is an indicator and target on diabetes and obesity, which is a 0% increase. This is the only target that does not speak about a decrease, but we are already happy between brackets if there's no increase. So this really means that this is a very complex topic to address. That's also why the WHO General Director has established a recommendation, a commission on ending childhood obesity, and that commission released its report earlier this year, the Commission on Ending Childhood Obesity, and the report follows a life course approach, but also speaks about the importance of involving many sectors in the prevention and control of childhood obesity. So they have established a recommendation under 6 components. The first one is related to the promotion of the intake of healthy foods. Then the second one on the promotion of physical activity. The third one, the preconception stage and also the care during pregnancy. Then the fourth one is related to the early childhood and diet and physical activity in early childhood. And then we have the fifth one, which is related to the school settings, and we will speak more about that. And then a 6th component related to the weight management. So this should be implemented as a package, but as you can see, the schools, they have a very important role in this because this is also where the children and the future parents, they learn their life skills and they adopt habits related to diet and physical activity that will last the rest of their lives. So now I will speak more about how a country can establish a school policy on diet and physical activity. So we have a document which is targeted at policymakers at country level to develop a framework, to develop a school policy. And it includes the steps and the policy options that countries can consider to establish a policy. So first of all, there needs to be a coordinating team. And the best thing that countries could do is to use an existing structure. In many countries there are health promoting schools initiatives or fresh initiatives which have already an existing multi-sectoral coordinating team with the presence of the ministries of education and health, and in some cases other ministries as well. So that team should take the lead and develop a situation analysis to establish the current health status of students. For that, they could make use of data from the TOESO supported global school-based student health survey. They should look at knowledge, attitudes and practices of children as well, see which programs are currently in place, what content of diet and physical activity is currently in the curriculum, and see also what are the available resources and capacity present in the country. Then they should establish a work plan and a monitoring system to define as well the indicators required to monitor, to set goals and objectives, and widely disseminate the policy, of course through the schools, but also through the wider community and to the parents and to the private sector as well. So the policy options that this school food policy could include are school recognition, policies related to the school curriculum, the food services environment, the physical environment, health promotion for school staff, and school health services. So these policies, they are all aligned with the health promoting schools and the FRESH initiative. Very important is the school recognition. This consists in awarding schools a special status according to their progress in becoming a school that promotes healthy diet and physical activity. Here as well, we don't need to develop a new system if we have already a system in place for recognition of health promoting schools or fresh schools. So we need to mobilize schools to participate in the program and provide technical support as well. And it is important to recognize that not all schools are at the same stage of development or that they have like the same economic resources, but it's more a recognition of the efforts that the school is doing as a whole to become a school, a health promoting school, or a school that works on implementing a school food policy or physical activity. Then the curriculum is a second component which is very important. So we need to make sure that health education is represented in the curriculum, that there is a focus on healthy diet and physical activity, which does not necessarily mean that there's a topic in the curriculum on that, but this could be incorporated like across the curriculum, which is often much better. So of course children need to have knowledge about what is a healthy diet, how much physical activity is required, but more important, the attitudes and the life skills should be developed. For example, in the case of tobacco prevention, of course we know that all children know that smoking is not good for their health, but they also need to have the life skill to resist to peer pressure in order to not start smoking. So knowledge is of course not enough. So speaking about life skills, we can also think about that children can learn how to prepare safe food, how to make healthy food choices. They need to know about how media work and how marketing works, and we need to involve teachers which are adequately trained. A few words about physical activity. Often when we speak about physical education, many schools and teachers and also parents, they say, well, children should learn the language and they should focus on mathematics and mathematics. They should not lose their time with physical education classes. But the truth is that physical activity at school is a win-win for students and teachers. Actually, research shows that children who are physically active, they learn much better, they have higher test scores, they can concentrate better, teachers lose less time in managing behavior, and we can see on this slide also the brains, a scan of the brains of children which have been active before a test and which have not been active, and we can see that the active children, they have much more brain activity and they can concentrate much better. So we also have global recommendations on physical activity for health. We have recommendations for several age groups, and in the case of school-age children, the recommendation of WHO is that those children should have at least 60 minutes of moderate to vigorous intensity physical activity per day. And if it's more than 60 minutes, that's even better, and that will provide additional health benefits. It should be mostly aerobic activity, but we should also include some vigorous intensity activities and muscle training and bone health activities at least 3 times per week. So if we want to reach this physical activity, we can think about physical education, but also other opportunities that schools have to promote physical activity. To summarize the benefits of physical activity, it improves the health and fitness of children, it enhances their cognitive performance, it has a positive influence on the children's psychological well-being, it can counteract risk behavior, and it decreases risk factors for future non-communicable diseases. In the school curriculum, of course, we can have quality physical education. There is a very good manual developed by UNESCO with support of WHO and other agencies. So I definitely would recommend following that manual if people are working on this. But of course, physical education is not enough on its own to get the 60 minutes of physical activity per day, which is recommended. So we can also think about extracurricular opportunities for physical activity, which can include programs of after-school gatherings, and active recess, morning lunch and after lunch exercises, traditional dances, school sports competitions. So there are many options to promote physical activity in schools. The third component is related to the food service environment. I will speak about the nutritional standards, the school food programs, the food service area, the vending machine, the food and non-alcoholic beverage marketing, and the food availability near school. Those are all places where we need to think about the food that is being served there. And we need to adopt some nutrition standards if we want to develop healthy eating habits, because it doesn't make sense if a teacher is giving a class explaining what is healthy food and what is unhealthy foods if the school food program or the restaurants are only selling unhealthy foods. So what the document recommends is to have all foods and non-alcoholic beverages available in schools to be consistent with national or regional dietary guidelines. And WSO is also establishing in the different regions nutrient profiles, regional nutrient profiles, which can be used to identify which are the foods high in fat, sugar and salt that should not be available in schools. Another important aspect is the food and non-alcoholic beverage marketing. This really affects the preferences and choices of children. Marketing is everywhere in the traditional media like radio and television, but also more and more on the social media and also in the school settings. So to regulate this, WSO in 2010 has prepared a set of recommendations on the marketing of foods and non-alcoholic beverages to children, which was adopted by the World Health Assembly. In the case of the school setting, we can see often marketing and advertising on posters on the school campus and textbook, in advertising in school yearbooks and newspapers, the school supply materials, sponsored equipment for school sports team, sponsored school events, school teams exchange students or inter-school competitions. So there are many ways that we can find the marketing and advertising in the school setting, and this is one of the things that this set of recommendation recommends to regulate, and this has also been emphasized very much by the Commission on Ending Childhood Obesity. And often it are the food and beverage companies that promote physical activity in schools, but at the same time they are also promoting their brands. A fourth component is the fiscal environment. Of course, we need to have safe and appropriate spaces and facilities so that children can spend their time actively. And we can establish partnership with communities for the use of the sporting facilities, and also the schools could use facilities of the community. And it is also important to promote safe walking and cycling to schools. We can think about measures like crossing guards at road crossings, secure bike racks in school, traffic-free zones, safe walking and cycling trails, and adequate lighting during hours of darkness. Then we should not forget about the school staff. Of course, school staff should be involved in this whole initiative. School staff should be motivated and should be healthy themselves as well. They are often role models for students, and if we promote the health of the school staff, this will improve their productivity and mood. We can think about in-service training on healthy lifestyles. We can think about a staff room with a healthy environment and serving healthy foods in the school cafeteria. Then the sixth component has to do with the school health services. So again, this can be run in partnership with local health services, and we can think about the measurement of body weight and height, nutritional screening, counseling of students and their parents to promote healthy eating and appropriate levels of physical activity, data collection for monitoring and evaluation, and participation in education and advocacy. So this is what I wanted to share with you, and it just gives some guidance of what can countries do to promote diet and physical activity. And we are always happy to provide additional support, and you can be in contact with us as well if you have any further question. Thank you very much for your attention.
Thank you, Leo, for that comprehensive presentation on what schools can do to develop a health policy around diet and physical activity. I would now like to open the floor for questions, and We've had a few come in, and I request participants to type in any questions they have or to unmute themselves and ask our presenters any questions or clarifications they'd like. There was one on the rates of obesity that you shared earlier, the global rates on obesity, and if you can speak to whether there is any difference in obesity rates between rural and urban areas. Is obesity more concentrated in urban areas? If you can speak to that question.
In general, we can say that in low and middle income countries, it's mostly a problem in urban areas, but of course it's also on the increase in rural areas. Anyhow, in developed countries, obesity is widespread both in urban areas as well as in rural areas. But anyhow, yeah, in countries in development, it is starting in the urban areas, but processes that we have seen, like this transition and the availability of fast food and processed food, it starts in urban areas, but it also later goes on to rural areas, and these processes are going very fast, like what has taken several decades to happen in Europe and Northern America. In 2 decades, this process can move in many low and middle income countries.
Thank you, Leo. And another question, this is from me on what the WHO's recommendations for public-private partnership around addressing obesity due to the increased uptake of processed foods should be, given that corporates, food and beverage companies have programs to for corporate social responsibility. What are some of the recommendations that you have or the WHO has around public-private partnerships with corporates on addressing obesity?
Of how WHO engages with the private sector, which is called FENSA. It is how we relate with non-state actors. But the question is more related to how countries should relate with the private sector in the case of public-private sectors partnerships. And the main rule that countries could follow is that there should not be a conflict of interest. So often, since the food availability in schools is so important for promoting a healthy diet, and since what is being advertised and the marketing is also very important to what children choose and consume, you could say that there is a huge conflict of interest when there is a public-private partnership with the foods and beverage industry. So I think countries should evaluate this and be very careful. We do think that private sector can be part of the solution, and of course they should participate in the implementation of all possible solutions and work on controlling their marketing and reformulating their products. But we do not believe that they should be involved in policy making, because then the policies will probably not be the most effective ones. But anyhow, it's something that countries should analyze, taking into consideration these thoughts.
Thank you, Leo. And do you have any or good case studies or examples where it has worked well, the public-private partnership, where governments have been able to engage with the private sector, with the food and beverage industry, in ensuring policy implementation is best it takes place without compromising on the greater objective?
I think there are some good examples in countries related to food reformulation, and salt reduction is a good example. Some countries, they also have agreements with food and beverage industry on marketing, but we could also see this as a first step towards tighter regulation, because anyhow the more comprehensive the policy is, the better it works, and it should apply also to all companies within a sector and not only to a few that are collaborating with the governments.
And Sung's just given the example of high tax on soda being a good policy, and if you could provide more examples on that, or share your perspective on taxation.
Yes, actually,
of beverages.
Recently we have developed an economic modeling exercise because our global action plan on prevention and control of NCD includes an appendix which has policy options that are effective, that are cost effective, that countries can implement. And after having done this analysis, the taxes on sugar sweetened beverage also appear to be a cost effective solutions that countries can implement, and there are several successful examples of countries like Mexico and Hungary having taxes on sugar sweetened beverages, and more countries are following and requiring requesting WSO assistance to support them in implementing these taxes. It has also been recommended by the Commission on Ending Childhood Obesity to implement a tax on sugary drinks, and these taxes can also be used to promote healthy food habits. In Mexico, for example, some part of the revenues have been used to implement water fountains in schools. So at the same time, it reduces the consumption of soft drinks, and it also the money can also be used to promote healthier food habits.
Great, thank you, Leo. Any other questions from the audience? Please feel free to unmute yourself and ask your questions.
Hi, Moineen. It's Doug McCall here, and first of all, thank both our speakers for an excellent overview. It's really heartening to see the coherence of all this. I wanted to pick up on partly your question, Mohini, the prevalence of these behaviors in middle-income countries. I was reading through the 2014 report, some of the slides that Leo had. It's pretty clear that in low-income countries, low resource countries, the rates of physical inactivity or the consumption of unhealthy foods and so on is quite low. But it's as incomes increase in certain parts of the country, then the transition, as Leo said, occurs. And so I think we need to try to package specific things that can actually work in a low resource setting, in terms of the school gardens or connecting to local farmers or those kinds of things that can be doable for that kind of situation. And that's I think the challenge is the marketing, the prevention of any marketing through the schools is very important, as Leo's already underlined. So it's really driving down or focusing in on some of those particular things that are achievable in a low resource setting that can be done. And so that's probably where we need to go. We had a seminar or webinar recently about substance abuse, and the same thing's happening in tobacco, and the marketing strategies. I don't know if anybody's been reading the series in The Guardian about the practices of tobacco companies in Africa. It's just horrific. And so we just need to do as much as we can within the school setting in terms of media literacy, all those other things that really kind of tailoring our response, because I think this is the transition is probably the most urgent challenge for low resource countries in terms of food and marketing. More of a comment than a question, but maybe the speakers can respond.
Yes, I fully agree. I think it's a very relevant comment. It shows that it is important that countries do a good situation analysis. And also I would like to mention we don't have a healthy diet to prevent undernutrition and another healthy diet to prevent overweight and obesity, but many actions or policy options that we can take are good for the health and of the nutrition of children and schools in general. And I think it's really important, even in settings where this problem of overweight and obesity is just starting. It's also a very good moment to intervene and have these policies in place, because later on it becomes much more difficult to revert back to a healthy diet. So countries that are actually giving a lot of value to their traditional food and diet, and I would like to mention Japan and Korea, which are some good examples where they really value their food habits. So that's also something to recognize and to put a lot of emphasis on.
Thank you, Doug. Thank you, Leo. Any other questions from the audience or comments? Caroline, I see you're typing a message. If you'd like to unmute yourself and ask the question, that might be easier. Okay, thanks a lot. Very comprehensive. Thank you.
Hi, Sung. I just reflecting a little bit on the fact that we're talking about this, about obesity, and then on the flip side, in a lot of the school health and nutrition work we do, we work with school feeding to address the needs of undernourished, lack of food, but quite a lot of the pieces actually align. I think, there's overconsumption, but it's actually poor choice of diet, which is something that even in the undernourished communities, they also have to do. So it's interesting for us to think about where quite a lot of the pieces we talked about still apply in communities where there is a lack of food, but we still want to provide quite a, the good nutrition information, the good physical activities, and the policies, and then looking at the long-term prevention of sliding from lack of food into poor nutrition. I think it'd be something for us to think about, that it is not only a high, it's not just urban, it's not just high-income countries with the obesity issue, but the actual programs are applicable for nutrition in general. So I just want to kind of think about that, since so many of us work with communities where we're doing school feeding.
Maybe just to add on that, and there was a question about good examples. I think the Brazilian school feeding program is also very famous, because it helps farmers as well to produce fresh fruits and vegetables for schools, and sticking with the healthy and nutritional norms that schools set for them. So it provides an opportunity for the farmers to increase their incomes, and at the same time children and schools have access to healthy fruits and vegetables, which improves their nutrition, both in terms of micronutrients as well as prevention of overweight and obesity.
Thank you for that comment, Sung and Leo, on looking at nutrition promotion in schools more holistically in all contexts. In some program implementers would need to look more at the obesity-related issues, while on the other hand, it might be an undernutrition problem that programs, schools, governments are grappling with. But the message on healthy diets and physical activities remains the same. I'd like to thank our speakers and our participants for attending today's webinar. We're almost close to the hour. And before we go, I would like to announce the webinar for next month, which is scheduled for the 15th of August. We'll be hearing from the WHO again, as the topic for the webinar is oral health. And Professor Paula Monihan from Newcastle University will be speaking at the webinar. The Newcastle University is a WHO collaborating center, and she'll be sharing with us some of the guidelines and experiences on promotion of oral health among school-age children. Another big area of work, and it also has a lot of intersections with promoting healthy diet and healthy habits in the critical primary years. So thank you, everyone. If there are no more comments, we'll be ending this webinar now. And we look forward to seeing you again in a month from now. Thank you.
Thank you, everyone.